Hello, everyone, and welcome to the MDA Engage DMD Community Webinar. I'm Scott Wiebe, Training and Community Relations Manager at MDA, and we are excited to be hosting this webinar today. MDA Engage is an educational event series that empowers individuals and families with knowledge and resources, with information presented on by our experts in the neuromuscular space. Be on the lookout for some information in your inbox and in Quest magazine regarding other MDA Engage events, some in person and some virtual like this, that will be hosted around the country in the coming year. To find out more about MDA and the Engage event series, please visit mda.org. We are honored to have Dr. Craig McDonald here to discuss the DMD care guidelines with us today. A few housekeeping items that I will note here before we get started. All audio lines are muted. There will be an opportunity for Q&A with Dr. McDonald at the end of the session, and you are encouraged to send in your questions through the chat window through this presentation, the little chat bubble on the panel at the bottom of your screen there if you're joining live here. I will moderate the Q&A portion at the end of the event, and I'll read the questions that you've submitted for Dr. McDonald, and we'll get through as many questions as possible at the end of the webinar. And finally, this webinar is being recorded and will be available publicly for on-demand viewing at mda.org. As we begin, we would like to express a very special thank you to our event supporter, PTC Therapeutics. Without their support, this event would not be made possible. And with that, I would like to turn it over to Dr. Craig McDonald. Craig, do you mind introducing yourself briefly and then carry on forward from there? Thank you very much.
Yeah, thank you very much, Scott. My name is Craig McDonald. I work at University of California, Davis, which is located in Sacramento, California. I've been involved in the MDA clinics for nearly 30 years, and I've also been involved with the development of natural history data in Duchenne muscular dystrophy. I've been involved with a variety of clinical trials related to Duchenne muscular dystrophy, and I was actually involved in the original 2009-2010 care considerations, and what we're going to be discussing today is really the recent update of those care considerations, which was recently published in 2018 by Dr. Bernkrant, Bushby, and their colleagues. It was really a major undertaking. Update these care considerations, and we should acknowledge the efforts of this group, which resulted in 3 peer-reviewed publications in Lancet Neurology. So with that background, Scott, if I could get started, that'd be great. So we're again discussing the 2018 care considerations. If we could have the next slide. Just as a matter of disclosure, I actually do consulting work on a number of Duchenne muscular dystrophy clinical trials for a variety of pharmaceutical companies. I'm really not pretty much agnostic to the company, and try to do whatever I can to help companies design clinical trials to get therapies into the clinic for the boys and men with Duchenne muscular dystrophy. If we could have the next slide. So the care considerations were really begun. This new version, this updated version was the committee, the working group steering committee began working on this back in 2014. So again, it was quite a long effort. 8 of the topics were addressed in this new updated version. In the original care considerations: diagnosis, neuromuscular management, rehabilitation management, gastrointestinal nutritional management, respiratory management, cardiac management, orthopedic and surgical management, and psychosocial management. But there were really 3 additional topics which were addressed by the committees in this new version. And these topics related to primary care and emergency management, endocrine management, including growth, puberty, adrenal insufficiency, and bone health, and then the topic of transitions of care across the lifespan. And I think it's really important to point out that really across the 3 manuscripts, and really all the committees. There was really a new emphasis across the lifespan, and the development of guidelines for lifelong Duchenne care. If we could go to the next slide. So I should point out at the onset, this is really a reference material that is available to all. But there's been an updated family guide that's been developed based on these updated care considerations for Duchenne. This is a published guide for families. It's called a Guide for Families, which is available online. This really represented a monumental task and great collaboration between Parent Project Muscular Dystrophy, the MDA, WorldDuchenne.org, and TreatNMD. And TreatNMD actually is making this available with a variety of translations on the TreatNMD website as well. But everything I'm going to be talking about today is really discussed in lay terms in this guide for families, and I would refer everyone to this excellent document. If we could go to the next slide. So the comprehensive Duchenne care team really consists of a number of specialists. It's patient centered. It's really the individual with Duchenne that's really at the center of all management considerations, along with the family, and there's also care coordination efforts with all these specialties. The neuromuscular specialist really tends to coordinate this comprehensive care, and the comprehensive care will generally involve neurology, rehabilitation, orthopedics, pulmonary management, cardiology, gastrointestinal, GI management, nutritionists, psychosocial specialists, primary care physicians, as well as physicians in urgent care or emergency care, as well as endocrinology. And it really is a comprehensive interdisciplinary effort, multidisciplinary effort, where these disciplines all communicate with one another and the patient and the family, and providing care across the lifespan, really from childhood through adolescence and transitioning into adulthood. If we could have the next slide. So I don't expect you to read this, but this is just showing you an example of one of the charts that's in the care document guidelines. The rows actually refer to the different specialty physicians that are involved in the care, specialists and allied health providers that are involved in the care. And there's different interventions, assessments and interventions which take place at different stages of the disease. So the columns, those 5 columns you see, go all the way from early diagnosis, the time of diagnosis, to the early ambulatory stage, and then also late ambulatory stage, the early non-ambulatory stage, and late non-ambulatory stage as well. So the assessments and interventions are based on the stage of the disease. It's also, I think, important to point out that even since the revised care considerations were published late last year, there's emerging data that actually discusses key milestones that are now available to really help us define these stages of disease. And these milestones can be based on objective criteria, based on time function tests, North Star ambulatory assessment performance, the Brook or the performance of upper limb assessment, as well as pulmonary endpoints to really define the stages of disease. And we'll get into a bit of that later this hour in the discussion. If we could go to the next slide. So again, just to show you an example here with neuromuscular management, there's approaches that differ at the time of diagnosis versus the early ambulatory, late ambulatory, early non-ambulatory and late ambulatory stages. If we could go to the next slide. So just a couple words about diagnosis. There really have not been significant changes in terms of the diagnostic approach since the time the care considerations were published in 2010. Each patient should be offered genetic testing, full sequence testing. A muscle biopsy is performed if the DNA results are not confirmatory. Genetic counseling should be provided within 6 months of diagnosis. Information should be given to the patient with regard to specialty Duchenne centers. This could be an MDA center or a certified Duchenne care center with PPMD. Families receive information regarding advocacy organizations, and also educational information is also sent to the primary care physician at the time of diagnosis. If we go to the next slide. This is the diagnostic algorithm that is actually part of the new care considerations. This is actually being used now to help educate pediatricians. There's a number of motor findings which you all are familiar with, early signs of Duchenne muscular dystrophy, as well as non-motor findings that would be more cognitive and developmental in nature. And then based on these findings and whether or not there's a family history of Duchenne, usually the early identification rests with the acquisition of a creatine kinase muscle enzyme test, and then subsequently a treatment algorithm goes from there. But there's been a lot of educational effort nationally for pediatricians, developmental specialists, to try to educate them with regard to the early signs of and symptoms of Duchenne muscular dystrophy, and really any child, particularly a male child, but there's other forms of muscular dystrophy that can be seen in females as well as males. But really, if there's developmental delay, a pediatrician should do a CK or creatine kinase test. And there's also a variety of videotaped educational materials that are available online as well. If we could go to the next slide. The genetic testing, again, similarly, the gene deletion and gene duplication testing is usually done initially, but really full sequence, next generation sequencing is often performed really in all patients. And this can use either MLPA or genomic hybridization arrays. The key is really to determine if there's an in-frame or an out-of-frame mutation. The location of the mutation, is the patient potentially exon skip amenable? So could they benefit from an exon skipping therapy? Do they have a nonsense or a stop codon mutation? And could be a candidate for a stop codon read-through therapy. So that is really standard of care, continues to be. If we could go to the next slide. This is just a map of the 161 MDA care centers really throughout the United States, providing care to children with Duchenne muscular dystrophy as well as other forms of muscular dystrophy. There is if we go to the next slide, there is a certain overlap between these MDA care centers and the Parent Project Muscular Dystrophy certified Duchenne care centers, which are also regionally distributed throughout the country. These are centers that have actually had site visits and provide a certain level of care for Duchenne patients. If we go to the next slide. First of all, the care considerations for steroids have evolved a bit with these new care considerations. Steroids are now started before the plateau or decline phase of the disease, so have been started very early in the course of the disease, really before any evidence of decline. And there's a recent publication by Ann Connolly and her colleagues, including our group, that actually showed that there were benefits to starting steroids even before the age of 3. And in that particular study, the high-dose weekend regimen was utilized in the very young patients. But the FDA recently, as you all are aware, the FDA has also granted full approval for deflazacort, making this the first glucocorticoid with a labeled indication specifically for Duchenne muscular dystrophy. And there is a variety of publications that are coming out that have been comparing deflazacort with prednisone. There are some key differences in terms of the pharmacologic properties of deflazacort versus prednisone. But most would agree that side effects such as weight gain and some of the behavioral side effects seem to be less with deflazacort. That's actually in the that statement's in the care considerations. And then also, I think a new trend is that the patients are really maintained on a therapeutic dose, unless otherwise indicated, really throughout the course of the disease. And then over on the far right, there are specific issues in the new care considerations regarding prevention and management of adrenal insufficiency. The steroid treatment will actually suppress the adrenal system, making patients at risk in the setting of medical emergencies and requiring stress dosing of steroids. And there's also information in the new care considerations about the prescription of IM emergency hydrocortisone, which actually should be provided to Duchenne patients who are on steroids, just so they could administer hydrocortisone intramuscularly on an emergent basis if there was a stress event that occurred or a patient was showing evidence of adrenal crisis. If we go to the next slide, I'll get back into this issue of adrenal insufficiency with the P.J. Nickoroff protocol, which Kathy Kennett from PPMD and her colleagues actually were instrumental in getting out to the community. But first, I'd like to talk about this recent evidence that we've published in The Lancet about the long-term effects of glucocorticoids on function, quality of life, and survival in a large cohort of patients with Duchenne muscular dystrophy. If we could go to the next slide. First of all, this paper really addressed this issue of the clinically meaningful benefits. And there are clinically meaningful benefits to steroids early in the course of the disease. And these benefits actually extrapolate or can be linked very closely to beneficial treatment effects during later disease stages. If we could go to the next slide. And then secondly, our article published in The Lancet showed that these early positive benefits of glucocorticoid treatment, defined by delays in the loss of clinically meaningful ambulatory milestones, really extrapolate to slowing of disease progression throughout the lifespan and also improved survival. If we could go to the next slide. Just to illustrate this is data showing the age at which children lose important motor skills. So this is the data on the left there. The graphs on the left show the age at which patients will lose, will actually transition to at least a 5-second standing time from the floor. They use the Gowers maneuver in this case, but the red data points there indicate patients who are treated with steroids consistently actually don't lose this skill until about 10 years of age on average, whereas the median or average age at which a child loses this skill if they're not treated with steroids is about 5.6 years of age. So again, steroids prolongs the ability to perform this test in a less than 5-second parameter, really quite substantially. So almost 4.5 years of progression. This is important because a 5-second standing time is one of those milestones that has been shown to be a hallmark of the onset of clinical deterioration or actually worsening of motor milestones and motor function over the course of the disease. Similarly, if you look at the age at transition to a 10-second stand from supine time shown on the left, that's again prolonged by about 4 years with steroid treatment in the red versus those not treated with steroid in the blue. If we go to the next slide, this again shows the age at loss of ability to stand from the floor on the left and age at loss of ability to climb 4 stairs shown on the right. And you can again see a delay in the loss of these functions with steroid treatment shown in the red versus non-steroid treatment shown in the blue. If we go to the next slide, this again is the age at loss of ambulation. So median age at loss of ambulation is about 13.4 years with steroid treatment, about 10 years of age with no steroid treatment. And that's about the same as it was in 1995, 10 years of age, when we published data on non-steroid treated patients. The average age at loss of ambulation without steroids was 10 back in 1995. That hasn't changed in 2018 to date, but steroids can actually prolong the age at which ambulation is lost by about 3.5 years. If we go to the next slide, similarly, as we start to look at patients who are spending time full-time in the seated position, the left data shows the age at loss of full overhead reach. The right data shows the age at loss of getting the hand to the mouth, so retained hand-to-mouth function and ability to feed oneself. And you can see, again, prolongation with steroids by about 3 years and by nearly 5 years in terms of that hand-to-mouth function shown on the right. If we could go to the last slide, this is really quite striking. If you look at the age at loss of distal hand function in Duchenne patients, the median age at distal hand function loss is about 31 years of age with steroid treatment and about 23 years of age in those patients that have not been treated with steroids. So again, showing the effect of steroids really throughout the course of the disease. If we go to the next slide, this is the data on the absolute capacity. The red bars show the values as a function of age with steroid treatment versus the blue bars are those not treated with steroids. What you see there is the peak value of the forced vital capacity with age and maturation actually is higher with steroid treatment, and also you persist with a higher level of forced vital capacity and a value at least above 1 liter forced vital capacity for a longer period of time with steroid treatment. If we go to the next slide. This was data actually published by a French group, again showing this relationship between the age at loss of ambulation and pulmonary function parameters. So the age of loss of ambulation in the blue, those are the patients that lose ambulation after the age of 11. The red or the black, the data points are those that lose ambulation before the age of 8. And you can see that those that lose ambulation later actually have a higher peak obtained breathing capacity, and they actually maintain their breathing capacity above that critical threshold of 1 liter for a longer period of time. And that 1 liter vital capacity parameter has been shown to be associated with survival. If we could go to the next slide. This was the data from our Lancet article, again showing this relationship between the age at loss of ambulation and the time at which patients will transition to this impaired breathing capacity below 1 liter. So the green data points are those that lose ambulation after the age of 13. The blue data points are those that lose ambulation before the age of 10. And you can see that translates to better pulmonary function longer. And this critical threshold of a 1 liter forced vital capacity also is shown to increase the risk of death in Duchenne patients by about 4-fold. So prolonging this pulmonary function is really important to survival of the patient. If we could go to the next slide. Again, our data in the Lancet article showed that all-cause mortality was reduced by steroid treatment with a reduced death risk by over 50% long-term in those that were treated with steroids versus those that were not treated with steroids. If we could go to the next slide. This is, again, this article that was recently published by Kathy Kinnett from PPMD and her colleague, Dr. Noritz. And this is the PG Nikolov steroid protocol for Duchenne and Becker dystrophy patients treated with steroids in terms of the recognition and treatment of adrenal suppression. And I would refer people to this protocol. If we go to the next slide. Again, this actually provides important information with regard to the stress dosing of steroids for minor procedures, minor stresses such as local anesthetics for less than an hour, moderate procedures, fractures, pneumonia, multiple teeth extractions, and then major procedures such as major surgical procedures or trauma, fractures, septic shock, burns, systemic infections, and other major sources of trauma. And this really requires this stress dosing of steroids, usually using IV hydrocortisone, and also the IM can be used in the home setting. If we go to the next slide. There are a variety, the care considerations discuss rehabilitation assessments and interventions. I'll just highlight these in terms of prevention of contractures or deformities. There's an importance in terms of stretching and use of AFOs and splinting at nighttime, exercise and activity recommendations, management of prevention of falls and management of fractures, management of issues related to behavior, learning, attention, sensory processing, assistive technology and adaptive equipment, promotion of participation, and then pain management as well are highlights and topics of the rehabilitation care considerations. If we go to the next slide. There are standardized functional assessments that are not performed in all patients, but a variety of these assessments are actually used in clinical trials and are now increasingly being used. Some of them are increasingly being used in the clinic as part of standard management and as assessments. And some of these more standard items include the North Star Ambulatory Assessment, the time function tests such as the 10-meter walk-run, the supine to stand, and 4-stair climb. In the upper limb, there's the Brook upper limb scale as well as the performance of upper limb scale, which is gaining increased usage in the clinic and also in clinical trials. If we could go to the next slide. So again, the Duchenne is complex, it's heterogeneous, but there really requires multiple different endpoints to really adequately evaluate the disease across the lifespan of a patient. And so there are the measures that are better for younger boys with Duchenne, other parameters that are actually quite useful in the late ambulatory stage, the performance of upper limb, and other measures are useful measures of upper limb function in the non-ambulatory patients. And then pulmonary function is used increasingly to guide our care management and our standard of care. If we go to the next slide. This is an example of the North Star. It's a composite endpoint that evaluates physical function across 17 tests with increasing difficulties. So the hop, run, jump items are more difficult for a Duchenne patient to perform. They're oftentimes acquired later in the course of the disease, and usually the items that are lost first in the course of the disease. The North Star scores these 17 items on a really a 2-point or a 3-point scale from a value of 2, able to perform the item, a value of 1, performs the item with difficulty or with some degree of compensation, and then a score of 0 would be unable to perform the item or complete loss of that item. If we could go to the next slide. This is an example of the older Brook upper extremity scale, which we use quite commonly clinically. A Brook score of 1, full overhead reach. A Brook score of 2, the patient can get their hands to the scalp. A Brook score of 3, you can get a weighted object to the mouth, such as a 8-ounce glass of water. A Brook score of 4, you can, with an unweighted situation, you can get your hands to the mouth. A Brook of 5, you can get your hands to the tabletop, but you still have distal hand function. And a Brook score of 6 it has a complete loss of distal hand function. And these scores have actually been used to even guide the criteria for which patients are eligible for use of the, or actually treatment with the precision medicine therapeutics. Some states are actually using some of these criteria and are providing those precision medicine therapeutics if the Brook score is a 5 or better, because there would be some degree of arm function that still could be spared with these precision medicine treatments. If we go to the next slide, the performance of upper limb entry items actually is very similar to the Brook. It runs in the opposite direction. And there's one item that's been added, the score of 4, which is the ability to get the hands to the shoulders. But again, it's full overhead reach, hands to the scalp, hands to the shoulder level, glass of water to the up to the mouth, an unweighted hand to the mouth, hand to the tabletop, and retained distal hand function, and then complete loss of distal hand function. If we go to the next slide, this actually shows since upper limbs function is a important indicator of skeletal muscle function in the upper extremity. These are skeletal muscle endpoints, as are the pulmonary endpoints, the forced vital capacity. You can see here there's actually a linear relationship between the percent predicted forced vital capacity and the upper limb measures by either the Brook or the performance of upper limb. And just an important point to here, if you look at the Brook score of 5, those patients have lost that hand-to-mouth function. Virtually all those patients are below a 50% vital capacity. And we'll get to that momentarily. Those patients should be on non-invasive ventilation. So when you've lost hand-to-mouth function, even if a patient has behavioral difficulties and can't perform a pulmonary function test, if that child or young adult has lost hand-to-mouth function, they should be likely on non-invasive nocturnal ventilation at nighttime. If we go to the next slide, cardiac management, I'll just point out a few key differences here. The new care considerations actually recommend cardiac MRI be performed in those that are 6 years of age or greater. Echoes are generally still the preferred assessment in those younger than age 6. And again, there might be certain situations where cardiac MRI may not be able to be obtained in a given patient or be available. If that's the case, then echoes should be performed. And most patients who get echoes or who get cardiac MRIs oftentimes will also get cardiac echoes as well. When patients are, by the time they're 10 years of age, or if they show early signs of cardiac fibrosis, they should be started on a ACE inhibitor or an ARB, an angiotensin receptor blocker agent. So one of those agents that actually is a blood pressure medication. It provides relaxation of the vasculature and provides less work for the heart. Those agents should be started early on, and certainly by all patients in all patients by age 10. Those agents should be started. Similarly, if at the time there's evidence of any cardiac impairment, beta blockers, usually carvedilol, is considered, as well as the aldosterone receptor blockers, such as spironolactone or eplerenone, are considered as well when there's evidence of cardiac dysfunction. If we could go to the next slide. The pulmonary management care considerations have actually changed quite significantly. Just to show you here, the pulmonologists were much more aggressive in terms of their recommendations for pulmonary initiation of nocturnal non-invasive ventilation. And the new guidelines actually recommend that at the time the forced vital capacity is below 50%, or the other parameters are achieved, such as a low maximal inspiratory pressure or identification of retained CO2, that nocturnal non-invasive ventilation should be started. And that's actually far more aggressive, far earlier than the previous care recommendations. The reason for this recommendation, it wasn't really data-based, but it was really to try to get treating healthcare providers to be more proactive at the use of non-invasive ventilation. There were also criteria developed for the initiation of mechanical cough assist as well in these care considerations. But I think that's an important new change in the care considerations, is this more aggressive initiation of nocturnal non-invasive. And that treatment approach has been shown to prolong survival substantially in Duchenne patients. If we go to the next slide. This again shows this linear decline in forced vital capacity. You can see when you're at 60% patients of a forced vital capacity, patients have impaired cough usually. Mechanical cough assistance is initiated. When the forced vital capacity reaches below 50%, patients are at risk for nocturnal hypoventilation, and bilevel ventilation is utilized. And then by the time the value reaches 30%, usually patients are requiring some degree of non-invasive ventilation during the daytime. This might be mouthpiece ventilation or even BiPAP during the day. If we go to the next slide. Again, this shows, this is just data, again, showing this linear decline in forced vital capacity. But you can see the steroid-treated patients who have an early benefit with regard to pulmonary function. If the steroids are initiated before the age of 10, that advantage actually continues over time, but the rate of decline is actually fairly similar across the steroid-treated versus the non-steroid-treated patients. If we go to the next slide. Again, this illustrates this. This is the data shown in yellow there, shows that in patients before the age of 10, the steroid-treated patients actually lose only about less than 1% of their forced vital capacity per year, whereas the patients not on steroids lose about 6% per year. So early initiation of steroids is really important in Duchenne patients. If we go to the next slide. This again shows this relationship, close relationship between this forced vital capacity measure and the proportion of patients starting any assisted ventilation over the ensuing 2 years. And you can see there's this direct relationship between forced vital capacity and need for assisted ventilation. If we go to the next slide. Again, this is again showing this relationship between forced vital capacity degrees of impairment and risk of death in Duchenne patients. And when you start getting to, again, values below about 1 to 1.1 liters, there is an increased risk of death in Duchenne patients. And so much more aggressive pulmonary interventions are required. If we go to the next slide. The new care guidelines actually give recommendations regarding growth and delayed puberty. The endocrinology should be evaluated if growth impairment is less than 4 centimeters a year or less than the third percentile. And then any patient who has delayed puberty at age 14, who's non-pubertal at age 14, should be referred to endocrinology. If we go to the next slide. These are the recommendations regarding bone health. I think just to hit the highlights here is that there is early monitoring of serum levels of calcium, phosphate, magnesium, alk-phos, parathyroid hormone, as well as vitamin D levels. And vitamin D supplementation is important, but patients actually are monitored in the clinic really on the basis of a lateral spine X-ray, predominantly, as opposed to a DEXA scan. And those lateral spine X-rays are really critical for identifying early compression, vertebral compression fractures, and even pre-symptomatic compression fractures. And then this guideline actually indicates which patients should be treated with bisphosphonates and how long that treatment should continue, and what the definition of clinical stability would be that would shift a patient more to a maintenance phase. And generally, the IV bisphosphonates are recommended over the oral bisphosphonates. So medications like IV pamidronate are generally recommended in the new care considerations. We go to the next slide. And this just gives some criteria about clinical stability. You can look that up in the document I alluded to. If we go to the next slide. Again, there are recommendations in the care considerations regarding psychosocial evaluation. I think the bottom line is patients should be assessed frequently and should be referred to mental health providers as needed. They should receive psychosocial evaluation at least annually. And there's an important component of screening for social or emotional concerns, cognitive delays, or speech and language delays as well. If we go to the next slide, please. There are screeners that the care considerations allude to. These are a variety of questionnaires that are used in either pediatric patients, adolescents, or parents of patients with Duchenne dystrophy. And these are fairly simple screening tools that really don't take long to fill out. If we go to the next slide. Again, this is the actual interventions that are alluded to. So there is comments in the care considerations about actual mental health interventions as well as a function of the stage of disease. If we go to the next slide. And then finally, there's an important component of transition to adult care that are part of the care considerations. This process of moving from parent-centered to patient-centered care should start early at 13 to 14 years of age. Time alone with a consistent provider is important to provide a young adult. And then discussions should occur early about healthcare, education, employment, assistance with ADLs, and transportation. If we go to the next slide. These are the critical issues that are part of this transition plan. Issues such as focus on healthcare needs, ADLs, education, employment, relationship issues, intimacy, transportation needs, and also accessibility issues. And some of these can be actually evaluated by use of a transition readiness toolkit, which are available at many of the clinics. If we go to the next slide. There's emergency care parameters. There's actually emergency cards that have been developed that are specific to Duchenne, which you can actually provide a emergency physician or an acute care physician that focus on issues of breathing, cardiac, endocrine, orthopedic issues, transport issues, as well as advanced directives. Next slide, please. And then just to end on, there have been a variety of efforts from the advocacy communities to really condense these care considerations. This is one of the examples called Imperatives for Duchenne MD, which is a global initiative to improve care. This document is a one-page overview of critical care considerations that are available on the parentproject.org website or a European website. And these are now available in 33 languages on the Treat NMD website as well. But these are so-called imperatives for Duchenne muscular dystrophy. Next slide. And that leaves us a few moments here for some questions. But thank you very much for your attention.
Thank you very much, Dr. McDonald. We very much appreciate you joining us and providing this information for the community. For those of you joining us live, please remember that your phone lines are muted, but you are certainly free to send in your questions through the chat window at this time. And you can access the chat window by clicking on the little chat bubble in the icon tray that should be at the bottom of your screen here. I will moderate the Q&A session by reading the questions that are submitted for Dr. McDonald to answer, and we'll get to as many questions as we can within the time available today. Dr. McDonald, the first question was submitted earlier in the presentation when you were talking about steroids, and there were some differences in the graphs between function with steroids versus function without. And really the question kind of boiled down to if you could talk more about when to start steroids.
That's a great question, and I think really this has evolved over time, and I think most Duchenne specialists now really start discussing the initiation of steroids at the time of diagnosis, and this is oftentimes as young as 4 years of age. There's now data out that indicates that there is some benefit in terms of gross motor development if steroids are started even before the age of 3 years of age. And I think, that discussion also has to be couched in terms of other available novel therapeutics, perhaps clinical trials that might be assessing designer steroids or alternatives to steroids that might have potentially better side effect profiles, and also the need for patients to be on steroids to actually participate in other novel clinical trials as well. But we generally start steroids as early as possible.
Thank you. There's a question sort of on the other end of the spectrum as far as starting steroids. Is there ever a time that it's too late to start steroids?
Yeah, I would say that there certainly is not. I think most patients can benefit from steroids in terms of preservation of upper limb function or potential benefits with regard to pulmonary function. I think there are some patients who are in those later disease stages that might have that might be quite significantly heavy, and we'd be really concerned about additional weight gain in those patients. There also might be patients that have issues of osteopenia or osteoporosis with recurrent fractures, where steroids might be a problem. And then occasionally there are patients that have neurobehavioral challenges that really make steroids problematic just in terms of their behavior. But fortunately, we do have some medications on the horizon which potentially could be used in those patients with more of the cognitive neurobehavioral challenges.
Great, thank you. There were a couple of questions. I'll kind of try to morph them together a little bit. When you were talking about steroids, you were talking about prolonged pulmonary function. And then you were also talking about the pulmonologist's portion of the care considerations and how the new updates to the guidelines have changed to a more proactive approach. Would you be able to talk a little bit about non-invasive ventilation and also steroids correlation with ventilation?
Yeah, it certainly seems as if and one of the hard endpoints we've now begun to evaluate is the time to a 50% forced vital capacity. And so, patients will generally, even though they're increasing their absolute amount of air they're moving, their percent of air they're moving or their percent predicted forced vital capacity is usually decreasing over time versus patients without Duchenne muscular dystrophy. And so I think it appears that with steroid treatment, you can actually prolong the time to that 50% vital capacity time point. So you potentially could theoretically delay time to needing non-invasive ventilation. The caveat, though, is that obviously with the side effects of steroids, if patients are a bit more Cushingoid and have some enlargement of their soft tissues up around the head and neck area, there might be some degree of airway obstruction that could occur at nighttime. So you could actually have some obstructive pulmonary differences that might actually lead to need for non-invasive ventilation even before that 50% value is obtained. So those children might actually require just the nighttime non-invasive ventilation when their forced vital capacities are even 70 or 80% or values because of the airway obstruction.
Thank you very much for sharing that. The number of questions about steroids. There are also some questions on when to conclude steroids and if there's a consensus on a certain time. Once non-ambulatory, one person asked, another person if there's times when steroids would be discontinued.
Well, I think one of the important considerations is that you really do have to titrate the dose or be aware of the dose in patients that are non-ambulatory and larger in body size. And since you're trying to dose the muscle fibers or the muscle mass, the muscle mass is actually fairly flat over time. So if the weight is continuing to march upward, you're really dosing the fatty tissue and the scar tissue and not necessarily the muscle tissue. So oftentimes when we do continue steroids, we oftentimes continue the steroid treatment at a fairly modest low dose than would be considered when steroids are started in a younger child. So we usually, if we continue steroids, we continue it at a lower dose. I think one could give consideration of potential weekend regimens and other regimens if the side effects of the steroids are not being tolerated. But I think given the data that with steroid treatment, the loss of distal hand function doesn't occur until the fourth decade, until the early 30s, versus 23 years of age in non-steroid treated patients. I usually recommend to all patients, even in the non-ambulatory phase, to try to continue steroids. I think the key is just choosing the right steroid regimen. I think when to discontinue is really when steroids are just not tolerated in terms of weight gain, bone health issues, or perhaps behavioral issues.
Great. We just have time for a couple more questions. One question came in that about the data you presented today being different than what this family personally experienced with their child. And sort of a related question with that, as far as those you noted, or the question states that you noted that steroids, those on steroids lost the ability to walk at about age 13. And if the question was if that was for a specific deletion or if that's sort of a, in general, most cases type of data. Would you be able to talk to that a little bit?
Yeah, that's a great question. And, a lot of times when these data are presented, it's really, combining, multiple patients and coming up with sort of more of, population estimates. And there's always going to be exceptions to this. But in general, if you have a median age at loss of ambulation of age 13 and a half with steroid treatment, the range at which you will see steroids is generally about plus or minus 3 to 4 years from that. So you might have some children that still even on steroids might lose ambulation, even before the age of 10. And other patients, and this could be due to genetic modifiers, differences in the actual gene characteristics of the patient. You might have some patients that actually continue ambulating even past the age of 16 on steroids. So there's a huge range of what the sort of normal experience of a Duchenne patient is, and the data I provided really is just more of an average. And obviously, there's going to be individual exceptions. If your child or adult, young adult child has actually is behaving differently, you have to really address those nuances with your care team and with your Duchenne treatment physician.
And there's a number of questions. We're not going to be able to get to all of them. Our apologies for that. But there are a few questions coming in about diet and some specific elements of diet, like intake of sugar and things like that. Is there anything that the care considerations speaks to on that you'd be able to share in a last comment here?
Yeah, I think I think the important issue is really getting ongoing assessments by a dietitian or a nutritionist. There's not a specific Duchenne diet that is going to necessarily be associated with slower disease progression or healthier status. But I think that there are some specific dietary nuances. Obviously, if you're moving less and expending less calories, the caloric estimates are going to be different for a Duchenne patient. If you've got mobility issues and your GI motility is going to be affected because there is dystrophin protein present in the intestinal mucosa. Yeah, you could, just because of some of those GI differences, your need for fiber and fruits and vegetables is going to be different as well. But I think it's important. I think the most important point is to really become engaged with your dietary and nutrition specialists who are part of your care team, really fairly early, and then also try to be a consumer of information that's evidence-based as much as possible.
Thank you very much, Dr. McDonald, and want to thank everybody for joining us for the MDA Engage DMD community webinar today. We hope this information discussed has been proven to be helpful for your family's journey with DMD. A sincere thank you to our presenter, Dr. Craig McDonald. Thank you, sir, for everything you've done to make this webinar possible today and all that you do for the DMD community in general. And thanks again to our PTC Therapeutics for supporting MDA Engage and making this webinar possible. There were a few comments and questions about how quickly some of this information went by, and please remember that this has been recorded and will be available on mda.org for on-demand viewing, so you can go ahead and re-access it there. Thank you again, everybody, and have a wonderful day.